The success rate at 10 years sits between 97 and 99%.
This is the traditional, conventional approach, yeah?
Conventional crown, yeah. And I would argue that is more successful than what you would be doing in an adult tooth. Name a restorative material in an adult tooth that you know has got a 97 to 99% success rate at 10 years. It's incredible. So there's nothing like this. So if you've got a patient who's got a clinical issue, I would encourage all your listeners, please do not do anything without x-rays. And if you can't get x-rays on that patient because of compliance issues, you really need to reconsider your ability. The strongest way to get that crown to sit down is the kid, because their jaw's a lot stronger than my thumb. And so I put a cotton roll in it, I get the kid to bite down really hard. And you get a floss with a knot in it, and then you put it on, and then you get your DA to put, dental assistant to put their thumb over the top of the crown, you floss down and then pull it out, and then go the other side, floss down, pull it out. I haven't done a strip crown on a primary anterior tooth in 5 years. And I'm so bloody happy I don't do them anymore. Keep in mind, each x-ray is the equivalent of around 6 bananas. Because 6 bananas got radiation in, right? So the radiation dose is insignificant, really. And I think I need your listeners to really understand that we don't treat children differently because they're children. You know, we wouldn't treat an adult and extract a tooth on an adult without an x-ray. You wouldn't do a filling on an adult without an x-ray. You wouldn't do a nerve-based treatment on an adult without an x-ray. So please stop doing it on children, because there is no defense for it. It's completely wrong.
This episode is such a wonderful resource and refresher on the whole crown technique. If you listen to the end of this episode with the wonderful Tim Keys, he's like the Aussie, you know, Aussie Man Reviews, those hilarious videos with a funny Australian accent comedy. Like, Tim has that voice where he should just do dental videos and a funny commentary. He'd be like Aussie Man Dental Reviews. And Tim spoke so well, so passionately, and so clearly about this topic, so that by the end of this episode, you will know the difference between the conventional stainless steel crown technique versus the more contemporary whole crown technique. When should you use which one? And all about this newcomer, the Zirconia children's crowns, and how the technique actually is really different, and how to prepare the tooth accordingly for a Zirconia crown, which is relevant both for anterior and posterior teeth. From knowing which cements to use and whether or not you should use local anaesthetic on a child, and something that Tim is very passionate about, should we be taking radiographs on children and at what age? What are the clinical and radiographic signs to look for to make sure that a tooth is suitable for this type of treatment, i.e. the whole crown treatment. Hello Protrusive, I'm Jaz Glanti, and welcome back to your favorite dental podcast. Like I said, Tim honestly just absolutely smashed this episode, and I'm so excited for you to learn from him. As you know, on Protrusive, we have guests from all around the world, but I have to say, there's something, I have a soft spot for my Aussie guests. I don't know what it is. They just come on and they put on a show every time. So sending love to all the Aussie Protrusive. You guys have been supporting me for over the years, but we're going to win the Ashes. Just had to put that in there. Every PDP episode, I give you a Protrusive dental pearl, and today's pearl is just the most wonderful summary of this entire episode. It is one of our famous Protrusive infographics. There are 2 ways to get this for free. One is, if you're viewing this episode on the Protrusive Guidance app, then thank you for being a member of the nicest and geekiest community of dentists in the world. Just scroll down and you'll see the PDF there, and please comment if you like it. Number 2 is, if you're not on our community, then head over to protrusive.co.uk/kids teeth. That's kids teeth. And when you enter your first name and your email address, I'll email it to you personally with the PDF in your inbox. Our infographics are pretty famous. The ones that we have on deep margin elevation, to which ceramic to use, which type of zirconia to use. We work really hard, especially the oral medicines one. Again, that was actually another Aussie guest we had on as well. So once again, hat tip to all the Aussie guests I've had on the show. But yeah, you're gonna love this infographic, so please do download it. And if you're not on the Protrusive Guidance community, what are you waiting for? Honestly, it's so nice to learn from everyone and to share my special snippets. And actually, there's a part of this episode that is going to be only on Protrusive Guidance. And this might actually sway me in a different direction, but you know, at the point of recording this in February, I know it's going to come out much later in the year, but I'm recording this in February 2025, and we've got 30,000 YouTube followers, and I'm so grateful, honestly, like, thank you so much. But there is a percentage of these subscribers that are members of the public. They are non-dental, they are patients of dentists, they are the public. And I feel a little bit uneasy about that, because we need our little safe space. This is dentist talk. Like, you're a patient. I understand that you're seeking information and it's good to be informed, but this is dentist speak. Like, this is not the best place for you to get information. And so what I worry about is some pieces of information that is like just dentist talk getting to the wrong ears. And so what I'm going to suggest is, If you want the full experience of this episode, please check it on Protrusive Guide. Even the free subscription on Protrusive Guidance, it'll be there. The full video without any interruptions. On YouTube, you're going to get a little bit of an interruption where I probably censor about 5 minutes. And the reason for the censor is a really appropriate and a really good recommendation that Tim makes. And it's totally appropriate. And I love him for what he says. But if patients hear this, then I worry about them taking it to their dentist. And it's just not the right environment. So this is very much secret dentist talk that patients shouldn't hear. It's a fact of life. And what we do on Protrusive Guidance is that we have systems in place that we will email you for proof. So I know that Protrusive Guidance is a safe space because it's not easy to get accepted. We ask you for proof that you are a dental professional. So if you're watching on YouTube and you have access to our app, just switch over now so you don't miss any of it. If you're watching on YouTube, still love you. Thanks so much. You're just going to miss out a few important minutes, which make a very clear clinical recommendation that you should be doing. And me and Tim feel very passionately about that. But yeah, we'll not go into it anymore. Enjoy the episode and I'll catch you in the outro. Dr. Tim Keys, so nice to meet you on here. Welcome to the Protrusive Dental Podcast. Your kids are asleep. It's a great time. It's morning here. It's evening where you are in Australia. So tell me, my friend, whereabouts in Australia are you? And are you a general dentist? Are you a pediatric dentist? I want to learn more about you, sir.
Mate, I live in a state called Queensland, which is a very sunny place, one of the more sunny places in the world. And I live on a location called the Sunshine Coast, which is a beach area. Very well known, and it's a beautiful, beautiful place. Absolutely. I'm a pediatric dentist, have been now for several years, and obviously prior to that was a general dentist. And I love my pediatric dental job. I enjoy it, and I love teaching too.
Would you call yourself a big kid? Would you refer yourself to like you're a big kid yourself?
The best part of the job of working with kids is that you can have a lot of fun. You've got an important job to do, but you get to do fun things and you get to talk about all sorts of crap that you can't talk about to adults. So you can have a joking time. The converse, the worst part of our job's dealing with parents, which sucks.
And you know, you live in the Sunshine Coast. There's a book, The Almanac of Naval Ravikant, and great book. And then this really clever guy, he says that in life, we don't spend enough time thinking about where we want to spend our lives, where we want to live. So what I want to know from you is, were you just born into there and then you just stayed in your Sunshine Coast, or did you make a conscious decision to design your life so that you live in a beautiful place?
Conscious decision, Jazz, conscious decision. You know, I live 800 metres from the beach, very close to a little canal system. It's beautiful here. Good surf. Good weather. Yeah. And look, I got my commute's 1 kilometre to work. I go through 2 sets of traffic lights. So if it's a bad day, it might take me 5 minutes to get to work.
That's amazing. I've experienced that joy before. That has its downsides as well. Like, you know, I know you got kids and we'll talk about that, but I've got 2 young boys. And so when I used to work literally right next to the clinic and I'd be like home in like 4 minutes, I never had time to read because I was always serving my children or whatever. And so therefore now I've got a commute back. I've got like a 45 to maybe an hour commute now. And so now my Audible credits are getting used up, which is great. So, you know, you got to take the ups and the downs. How old are your kids?
I've got a 4-year-old, a 3-year-old, and a 1-year-old.
How do you do it, man?
Alcohol helps. Few beers, mate. Absolutely.
Lovely. Why peds? Why did you go into peds?
I feel like it's the last real remaining specialty where you can actually do a lot and try to still refine your skills within that. So by that, I mean, it's not just doing fissure sealants and crowns and fillings and extractions on kids. You know, you can do surgical extractions, exposures and bonds of canines and teeth. You can do some pretty gnarly sort of auto transplants. You can do endodontic treatment as well. So there's a whole scope of things where you can still focus on certain stuff. I quite enjoy dealing with children. I thoroughly enjoy the job. It does get fatiguing. Like I think 3 to 4 days of clinical peds, like in the clinic dealing with kids and anxious kids, can get quite emotionally draining. So therefore it's really nice to have that 1 day a week or a fortnight under general anaesthetic where I could just somebody else's behaviour managing ketamine and propofol.
Really fascinating. It reminds me of people I speak to whose spouse happens to be a chef. And so, you know, when they're cooking all day long, they don't cook at home because they're just done with it. So how do you, right? This must be the toughest gig. Like that week where you got like anxious children all day long, and then you have to come home to your own kids, right? How do you make sure that the dad mode is on?
Mate, it's hard. Like I leave home and I have screaming children from 6 a.m. I go to work and I've generally got screaming children for 8 hours. And then I go home at night time and I've got screaming kids until 7. So I have 13 consistent hours of screaming children. And you're right. Look, it does get a bit sad sometimes that I can use up all this patience on other people's kids and you go home and you think, oh, shit. But, yeah, what do you do, right? What do you do? But I've got to say, everybody that's got older kids, and Jazz, I don't know how old your kids are.
5 and 2.
But 5 and 2, yeah. So you'd hear the same advice. Anyone that tells you, they say, you're a bit in the trenches now, but these are actually such magical years. You got these
100%.
little humans who all they want to do is spend time with you. And sometimes you get a bit over that, but that's all they want to do. They just want to spend time with you. And I really do. I don't work weekends. I don't work late nights other than doing podcasts after the kids are asleep. I think for all of us with kids, it's just that really valuable special time, which that's that 20% you got to think about while you get through the 80% grind of just screaming battles, right?
It's an absolute joy, overall. I totally agree. The book I'm listening to at the moment is Hold On to Your Kids by Gabor Mate and Gordon Neufeld. Have you heard of this book?
I haven't, no.
Okay, so I'm early into it, but I love it because it's talking about the culture we have brewed as a society. We have created this culture of sending our children, encouraging them to have attachment with their peers, and then children, it's like you can't serve two masters. And so what happens is that because now they are attached more to their peers than to their parents, then this is why they don't want to hang out with their parents anymore. This is why they're sort of moody at home. And we think this is a phase, but what the book argues is that actually this is a new phenomenon, and we need to make sure that we hold on to our kids. Their primary attachment and guidance in life should come from their parents, not from the peers, because otherwise the blind leading the blind. So that's a really fascinating book. I thought it'd be nice to mention it in the pediatric-based episodes. Lots of parents listening. The other one I'm listening to, thanks to a recommendation from someone in the community, is The Anxious Generation. How the newer generation and screen time is really messing up our kids' brains. We know this already, but like it goes deep into the science. Any guidelines you follow at home, just as parent to parent, on screen use?
Mate, we're very limited, but I'm fortunate that our kids are young. So we've got the point now where we can, to some degree, control them. Yes, there'll be a big screaming fight and argument, but we're pretty rare. Like there'll be multiple days in the week where they get no TV. And then if so, they might get short periods, 15 minutes, like after they've cleaned up the playroom and things like that. So it's used just as a reward basis. Don't get me wrong. Occasionally when it's like 5 o'clock and you're late for dinner and you got 3 screaming kids and it's chaos, you're like, shit, we've got to crack this. But we actually found about a year or two ago, we were finding that we were resorting to it too much. And I'm the same as you. I just feel like, particularly where I live, like our winters at worst are like, 12 degrees to 25 degrees. That's how cold a winter, right? So
that's Celsius for those Americans out there. So it's pretty good.
Yeah, absolutely. So we've got no excuse where I live not to be outside and playing. And we've got a fenced house, so they can have a good time. But yeah, I agree.
Lovely.
Absolutely. No. I think there's a few things, there's a lot of ultra processed foods and that sort of stuff, a lot of sugar, a lot of TV. And I'm so happy that, Jazz, you look similar sort of age to me, that we grew up prior to social media.
Big time. And so the book argues, and I'm glad you mentioned this, because I remember growing up and I would be away from the home, like I'd be like 9, 10, and I'd be like in a distance park, maybe 500 meters, maybe a kilometer away from the home, and I'd be in the park, no phones, no contact, and I would just come home 6 hours later or something, okay? And parents were accepting of that. Nowadays, we can't bear to not know where our children are at such a young age and for them to just go and walk off. And so this is what the book argues is one of the biggest tragedies of our time. So it's interesting to talk about this.
Absolutely, I agree. Yeah. I mean, to be honest with you, but I think I would struggle to let my kid... I did the same. I used to go for a bike ride, 15k away, but I still got young kids, but I struggle to feel like I would let them do that. It'd be emotionally tough for me, but I don't know. We'll see what happens when we get there, hey?
Yes, exactly. It says the society of brood. But I enjoyed that pre-chat. Thank you so much, Tim. I'd like to learn about why someone goes into his particular specialty and learn a little bit more about the individual. And it's nice to learn about you and your family, and just, parenting advice is nice to talk about, as well as books. But the main crux of today is hall crowns, or rather formerly, we used to call them stainless steel crown technique versus hall crowns, but now the new player, Zirconia. And I was saying to you before we hit record that actually my wife, she did a MSc at Eastman in Pediatric Dentistry, and her thesis, a master's thesis, was on Zirconia hall crowns versus stainless steel hall crowns, basically. So very interesting. I believe the only supply, and you correct me wrong, is it New View or New Smile that create these Zirconia?
New Smile. So there is another company called Sprig, which came later to the game, but the predominant market in the world is a company called New Smile. So they made the Zirconia crowns, which I think those particular crowns are not suitable for a hall crown, and we can go on discussing that why, but they've created another crown which is like a resin-based bisacrylic crown called BioFlex, which they're trying to say is a bit more more like a hall crown. But I think what we should do, Jazz, is let's go through the pros and cons and things of stainless steel crown zirconia, and we'll talk about the pros, cons, limitations, and how we can do it. But I'd be very fascinated to read this thesis.
I'll send it to you. I thought I'd just mention that as a little background. But yeah, where I want to start in this podcast is for our younger colleagues, and actually, you know what, for our older colleagues, because they probably qualified at a time where the technique wasn't being used so much, or not in the way that the hall crown suggests. They were still prepping perhaps. And so let's talk a little bit about the history of using stainless steel crowns for pediatric molar teeth and how that's evolved, and when and why the whole technique and what it is.
Yeah. So, Jazz, essentially the way we have managed decay, as many of us are aware, has changed, right? And the reason is we're moving away from this infected and affected dentine and things. So dental caries, the outcome is a cavity, okay? Once you got a cavity, you can't tend to remineralize it. Without plaque control, it will continue to progress. And that's our justification for putting fillings in, right? Restoring form, function, and aesthetics. So for pediatric teeth, there's significant limitations to putting intracoronal restorations in teeth. So my thesis was a part of a series of surveys of dental practitioners nations-wide, so internationally. And so for us practitioners in Australia, what do they use to treat kids' teeth? And the dominant material used for primary teeth was GIC, followed by composite resin, and then some, RMGICs and some stainless steel crowns. And you'd find the variability was significant. You'd have 25, 30% of people using this, 30% using this, 20% using this. While if you asked for permanent teeth, it was 85% composite resin, right? So why is there so much variability for primary teeth? And I think the reason comes is that there's not a great deal of research on this. And essentially, everyone's just having a crack at it. My supervisor's using Fuji, but a few GICs, and that works really well. The issue that we've got, primary teeth take 6 months to form, not 3 years. The enamel that's present is much thinner. It has a much lower mineral content. Now, we use predominantly resin-based or chemical adhesion. Yes, GIC has that ion bond, but the vast majority of our resin restorations, they're just glued in. And we don't have, even despite trying to go for it, still our best bond we can form is with enamel. And so you can imagine if a primary tooth begins its life with less enamel, and the enamel that says got less mineral content, it's much more difficult to glue a intracoronal restoration into the tooth. Our main drawback with GIC-based materials is that they're structurally weak. And children, because they've got their flat occlusal plane, can actually have higher bite forces on their marginal ridge than we can as adults. So, but why therefore do we use a inferior strength material to restore primary teeth? And so the failure rate for a two-surface intracoronal restoration at 3 years sits at about 35 to 40%. That's what our evidence shows us. So that means if you've got a child in your clinic...
And that's any restoration, that's GIC or composite, any direct restoration, yeah?
Much higher failure rates for GIC. A lot, like if you look at the American Academy of Pediatric Dentistry and other guidelines, a lot of them are recommending, once you get past a single surface for GIC, it's really not indicated. I'd verge on, it's contraindicated. It's a temporary restoration.
But while RMGICs, does that make a big difference? Because, they are two different materials. RMGIC is, far mechanically superior.
Yeah, but it still can't put up with the rigors. If you got a 5-year-old and you're putting a DO in their first primary molar, you got 6 years of occlusal forces on that. I guess the question, Jazz, to you is, would you expect 6 years to survive in an adult tooth with an RMGIC as a two-surface restoration?
Put it this way, it's not predictable treatment. You wouldn't say to the patient, yeah, I should be fine for many, many years to come. Whereas with a composite, you definitely could say that, yes, I expect this to last long. Whereas you're reducing the predictability, for sure.
Correct. And so the same thing applies to kids. And so therefore, composite resin has a higher success rate when it's small. The moment you move past the contact point, so it gets wider and extends onto the buccal or lingual surfaces, you're actually now moving into a 3-surface intracoronal restoration. And it is a contraindication to place an intracoronal restoration in that for longevity. Why else? If you want to put an RMGIC in, what's in it? What makes it stronger?
So it's the silica.
Well, resin, right? It's a resin-modified glass laminate cement. Is resin moisture resistant? No.
Of course not. But there's the same issue with the composite.
Correct. So if you want to do an intracoronal restoration that you want to survive, you need local because you got to drill, and you need rubber dam on because without rubber dam, your failure rate increases by 200%. And then even if you got a two-surface resin put in those areas, your composite failure rate can still approach about 1 in 5. So if you got a kid, you put 4 fillings in, you would expect at 3 years, to be getting close to one of them failing at least. Keep in mind that's an average. Placed under rubber dam with local anaesthetic. Can be hard to do. So therefore, we moved to stainless steel crowns. So a stainless steel crown on a primary tooth was traditionally, as you said, the conventional technique, and it was reserved for those teeth that were heavily compromised. Large multi-surface areas of decay or pulpotomy-based teeth where people were scared to put a filling. The success rate at 10 years sits between 97 and 99%.
This is the traditional, conventional approach, yeah?
Conventional crown, yeah. And I would argue that is more successful than what you would be doing in an adult tooth. Name a restorative material in adult tooth that it's got a 97 to 99% success rate at 10 years. It's incredible. So there's nothing like this. So in the UK, there was a particular dentist who was audited because she was claiming a lot of NHS, I think it is, a lot of the rebates, but she was doing so many stainless steel crowns. It was just like, this can't be right. This lady's doing too many. And they went and audited her records and found out she was putting them on non-invasively. So this goes back to that decay scenario. If we can deprive the bacteria of a food source, they will die. But it has to be well sealed. And that's where stainless steel crown overcomes that, as long as you have sealed the decay. So they audited her and actually found out her success rates were brilliant. And this is what became the Hall technique. Now, pediatric dentists were actually one of the more resistant groups to adopting this technique. So they said, this can't be right. We've got to sit down and drill it and put a conventional crown on. Otherwise, it's going to be too uncomfortable. It's not going to work. There's actually studies done, and there was 2 comparison postgraduate pediatric groups in the UK that did this. They treated 836 teeth and had a 77-month follow-up. One group did conventional crowns and one group did Hall crowns.
Before we talk about the success rates there, because I just want to clarify to our audience, what actually does a conventional technique entail and what makes a difference to a Hall technique?
So a Hall technique is no preparation. So you put 2 separators between the tooth and you leave them there for a couple of days. Then you come back and take the rubber bands out. And so now you've got a little bit of room to fit your crown. Then you just size up the best size you can. And the more you do, the more comfortable you get at doing the size. You still got to crimp and adjust the crown. So crimp's like bending the crown to make it tight. Then you fill it full of glue. And this is probably the best place to use GIC in kids is within a stainless steel crown. And you squish it on over the top. Okay. Now, it's heavily reliant on your diagnosis and investigations prior, which I think we'll cover. But in comparison to a conventional crown, and a conventional crown is where we used to just, you numb a kid up and you take about 1.5 mil off the top. Then you get a burr, like a stiletto or what's called a flame burr sometimes. And you just sort of open the contacts up and round it all around a little bit. Then you get a crown, try it on several times, bend it, adjust it, fill it full of glue and stick it on. Okay. So there are your differences. Now, you still need to do conventional crowns in circumstances where Hall crowns are contraindicated or following a pulpotomy. Okay, so you still need to know that skill set. But going back to this study, the Hall crowns are non-invasive, filling full of glue, squishing on, when it met the guidelines, which we'll go through in a second. The success rate for that was 95.8%. The success rate, Hall crown. Success rate for conventional crowns was 95.3%. Statistically insignificant. So that converted us. So you got, that's a lot of kids. That's 400 kids, right? And that's like, okay, shit, this technique works.
Hello, YouTube Protrusive. I know you're watching on YouTube and I hope you're enjoying this episode so far. But I wanted to highlight, in case you don't know yet, we have an amazing viewing experience on protrusive.app, our website, our network, our platform. So I just want to spend a minute to show you what this looks like. On the left side, you see the navigation, and when you join the app, you get a 1-minute video tour of the entire network. Now, in terms of where the magic happens, that's in the Protrusive community, because you might come for the content, but you'll stay for the community of the nicest and geekiest dentists in the world. We have all these polls, we have a chat group, there's always active chats and dentists helping dentists. And really what I want to do is create a really supportive environment that's not like the environment we have on Facebook, and it's built on the values of niceness and geekiness. If you are nice and geeky, you belong here. Now, to make this a safe space, we have a manual process of approval. We actually verify that you are a dental professional before you get in here. So we have hundreds of applicants a day. So if it's been about 2 days and you haven't heard anything, either something's in your junk or you need to reach out. If you're still waiting to join your tribe, email marie@protrusive.co.uk. That's MARI@protrusive.co.uk, and she'll investigate what's happened. Now, all the videos you have on YouTube are also on here, but you actually have some extra ones for free that you don't have on YouTube. So you get some bonus content that's not on YouTube. And actually for the future, I'm not taking things out of YouTube, but some things are not appropriate for the wide wider public, and I want to sort of safeguard that information, which is like dentist talk, if you like. So that's why a lot of the content is only here and not on YouTube. So you're kind of missing out if you're not on here. That's why I'd love for you to join there. And if you join one of our paid plans, then what you get is access to the CE quiz, like this one, and you can get CPD or CE certificates, and also you get our premium notes. So these are a great aid memoir or revision for an episode to really cement your learning. And whilst we have ads and YouTube places ads on YouTube, we don't have that on our network. So for the paid plan, you get to see all of the premium notes without any of the ads. And of course, you get to support Team Protrusive and help us to continue what we're doing. I'm just going to gloss over the Protrusive Vault, which has all our infographics and downloadables. These are all our masterclasses at this moment in time, and we're always planning to add more. And if you look at them, there's about 1, 2, 3, it's about 7 of them. But actually, if you look at the replay section, some of the live masterclasses that I've done and some of the training that people pay for on other websites is all on there, included as part of the masterclass subscription. And if you're a student, don't fear, we have a special section for you with all the student notes, which anyone can access. So for example, here is one on exodontia. So it's all there waiting for you on Protrusive Guidance. Please head over to the website, which is protrusive.app. Make an account on your browser. This could be Safari, Chrome, however you want to do it. And once you've made your login, then you can download the iOS or Android app and then log in through there. So the reason to make the subscription primarily on the website first is that you get access to a free trial, which you don't get if you do make an account on Android, iOS. If you make it on the website, you get access to the free trial, and you get our best price if you sign up through protrusive.app. So our best deals and free trials are only on protrusive.app. Of course, we always put the link below in the description, and thank you so much for enjoying our videos on YouTube. But it's now finally time to level up your experience. Back to the episode.
Let's say you've done a beautiful clinical and radiographic examination and you picked up a couple of holes in the mouth. With the Hall crown, the main key is, at this point, according to the guideline for this, which is once again published UK, you need to be able to have a clear radiographic band of dentine between the cavity and the pulp. So you're looking for about 1 mil. It shouldn't be something where you're like, ooh, I think I can see it. It should be, yeah, I can see hole and I can see decay. And what we're thinking there is that you've got like a bit of insulation, okay? At that point, Hall crown is eminently suitable. You can treat a single surface, 2 surface, 3 surface, doesn't matter. As long as you've got a radiographic band to...
And if it's cavitated or non-cavitated, does that inform the prognosis? The broken marginal ridge? Okay, good.
No, doesn't change it. So we've moved away from that thinking that a marginal ridge involves pulpal involvement, therefore you require pulpotomy. You only need a pulpotomy if radiographically the decay is into the pulp, or if the symptoms are guiding you to question the health of the pulpal status. But if you've just got a standard hole, whether you can see it clinically or not, on your x-rays, and you've got that radiographic barrier and the kid's just saying, oh, it hurts when I eat, happy days, hook in. Okay. Now, where would you do a Hall crown over an intracoronal restoration? I would probably encourage you to do a Hall crown in most circumstances. Why? Because you don't need local, you don't have to drill it, your success rate's higher, and so it's cheaper, quicker, and easier to place. Happy days. What's your big drawback? Aesthetics. And what is becoming increasingly more important for people these days is aesthetics. And that's obviously why we'll talk about zirconia crowns shortly. Now, with the Hall crown, so you need a vital tooth with decay not involving the pulp. 2 other things I want your listeners to look out for. Because you're not adjusting the occlusal surface, the ability for the crown to sit down towards the gum level, it can only sit down as much as the crown will go down, right? And when it hits the top of the tooth, it'll stop. So if you've got a really deep hole, not towards the pulp, but down like under the gum, I need you to think, if I put the silver crown, the stainless steel crown on this, without taking anything off the top, will the crown actually seal the cavity? Because what happens if it doesn't? Well, the decay continues to tick away, and then you end up getting sent to me. I pulled the tooth out, okay? So that's tip number 1. If you can see decay that is about the gum level, I would start thinking my crown is going to struggle to seal that, okay? If it's above gum level, you're probably going to be sweet. If it's well below gum level, you're going to struggle.
So well below gum level is obviously okay, as long as A, it's vital, and B, it still has that band of dentine. It's still okay to treat with the Hall crown approach, except what you're suggesting here is perhaps consider some occlusal reduction?
Yeah, the problem is, I don't know why, Jazz, but if I pick a little flame or stiletto burr up and go in approximately without local, the kids don't tend to feel it because there's reasonable enamel there. The moment you seem to pick a footy up and touch the top, the kids do seem to feel it. So when I'm looking at my x-rays and clinically, I'm looking at how deep down towards the gum the decay goes, and if it gets below gum level, despite meeting the other criteria, so plenty of space to the pulp, symptoms are sweet, I might say to them, hey, we need to do a conventional crown here because I need to numb them up, take some off the top to get the crown to sit down far enough to seal the decay. The second thing I need people to look out for is when you've got a clinical cavity that's present, usually on the D. The D blows before the E, or for the other people that know that, the first primary molar goes before the E, the second primary molar. Reason is it's been there longer and it's got much thinner enamel on it, so it tends to blow first. What can happen is you get a clinical cavity on the first primary molar and then the tooth behind it tips into the hole.
Hate that scenario because it just makes everything so awkward and tight.
Correct. And then how do you get a crown? You need to do like an S-bend. It's got to get like a dog leg to get around the second primary molar to seal it. And that's once again where you might look at the scenario and say, actually, I need to numb the kid up and do a conventional crown. But they're your two main ones. They're the two things just for tips for young players. You're getting started. I would say don't pick a D, pick an E. So second primary molar, they're easier teeth to manage. Pick obviously a very compliant child. And if you're a bit concerned and you're worried, like you to think, oh shit, I don't know if I actually sealed that decay, take an immediate x-ray. So before the cement sets, so if it has and you haven't sealed it, get the crown back off and reassess your plan. And maybe you need to numb them up and take a bit off the top.
Okay, that's wonderful. And so the questions I have clinically on the back of that is just some common questions I actually see on forums on this technique is, let's imagine a scenario where you have a, let's say 5, 6, 7, 8, an 8, so lower right D for some of our listeners. It's clinically cavitated, but it's equigingival caries and you have, it's vital, you have that band of dentine. So it's suitable for a whole crown and you don't have any space issues per se. In that scenario where, because it has got an obvious cavity, the guideline says, obviously, if you can get a seal, you don't need to remove the caries. But in that scenario, it's so tempting just pick up an excavator and just scoop out some of that, the most superficial decay. Is that something that you do because it's just so easily accessible? Just scoop it out in case there's some bread or cookies stuck in there or something?
Oh, absolutely. You got to get the food out. Yes, please. Yeah. So definitely give it a clean. But you don't need to scoop out tooth structure because once again, that boils back down to the understanding of decay. Decay is not an infection. It is a biofilm related disease. So if we can, plaque bacteria related, right? So if you can kill all the germs there because they're deprived of a food source, don't worry about it. Don't pick anything up. Just make your life easier, quicker. Don't pick a drill up. Just squish it on.
Yep. And then just the point there to make is if you see an obvious bit of food there, just get rid of that, cleanse it in that way basically and get rid of it. And then the other scenario is when you are a bit more experienced, and then I've done a fair few whole crowns in my time, don't see children anymore, but I used to love doing them. And when I did them, sometimes when it's a bit tight, we need to then, zip the contacts just to allow it to seat a bit better. And in that scenario, like you said, I also experienced that, okay, children were okay with that. They didn't need any LA for that. That was okay. In that scenario, you're able to then seat it, which is great. Now, going back to the stainless steel crown, the conventional technique, is there sort of like a hybrid technique whereby you're doing the conventional technique, you're zipping off the contacts, but you're not adjusting the occlusal for whatever reason. And then essentially what you have is kind of like a modified approach because with the whole crown, they're going to have supra-occlusion. Their mouth's going to be propped open. And so is there a place to utilize that approach either to make your treatment quicker, more efficient? So giving the patient LA, you are zipping the contacts, but you're not then doing the occlusal reduction because it will, dial in or it will settle occlusally anyway. Is there any need to do the occlusal adjustment?
No, the short answer is no. I agree with you. There is certain circumstances where I've just got to zip between and I won't numb them up for that because they really don't tend to feel it. I would still, in my hands, I still sort of call that the whole crown. For me, conventional crown is when I'm picking a needle up and I'm giving LA, which is pretty rare on its own. Usually it's when I'm doing a pulpotomy or I'm doing like back-to-back things. I'm extracting a tooth and then I'm like, oh, I'll just put this on at the same time. But vast majority of the time, absolutely. You can just sort of zip between if you need to. But I'd say to most people, the vast majority of times, 80% of cases, you're not going to need to pick a single drill up. You're just going to need to clean the gunk out. You'll have seps in, leave them for a couple of days, pull them out, you'll have room, and on you go.
And at the point of placing, just a little technique tip, at the point of placing, I placed, and then what's the most efficient and best way to remove that GIC cement without then removing the crown or causing discomfort to your child?
Yeah. So my usual discussion with the parent or child before we've even got to that point is, I describe how we're going to do this technique, and I usually describe it in such a way, like you're asking before about how does it work. My analogy I give to most parents is, imagine if I had a water tank and I put you in it, Jazz, and then I filled it full of concrete. How would you go? Not very well, you'd be dead, right? And that's what's going to happen to all the germs in here, okay? Now, I need to put rubber bands between the teeth. Your child's going to be most upset by this bit out of the whole procedure. Why? Because it hurts. It's like having a big chunk of corn stuck between your teeth. Usually at this point, I say to the kids, hey, you ever eaten corn before you eaten meat? You know, it gets stuck between your teeth. It's really annoying. So what we're going to do is I'm just going to floss this in. It's going to be a little bit annoying. Always do the harder contact first. So usually on a D, do between the D and the E first, and then do the D and the C. Right? If you're doing the 6, do the most, whichever one looks the dodgiest, do the hardest one first. And then the kids usually get a bit upset because it's hurting and they want to pull them out. I always just reassure the kid and the parent that every minute it sits there, it's going to get less uncomfortable because we're making space. And that's the worst part of this whole procedure. So usually when they come back for the Hall crown, I've got the space, right? Now there's a particular set of pliers called Howe pliers, Howe. So there's 2 pieces of equipment you need to place a stainless steel crown well. There's crimpers, which sort of tighten the gingival margin and make it sort of click on and retain better. And Howe pliers, they've got like flat ends. They're like little pliers with just flat ends. And what you do is you actually put them on intraproximally on the crown and you can squish it a bit mesodistally. So they're brilliant for those cases where you're lacking a bit of space. Okay, and then it makes it a bit wide buccolingually, so you got to crimp that in. That will help with, you get those 2 things, with good set of separators, you're pretty good. Then I clean out the gunk. Let's say I've sized it up pretty well. I've eyeballed it. Sometimes I sort of nearly put it on. Can be a bit uncomfortable. I don't tend to put topical anaesthetic on the gum anymore. I tend to find the kids just got the taste of it half the time and they hated it. So I just pretty much now just load the crown up with a runny glass ionomer cement, such as like in Australia we call them Fuji 7 would be the type. And then
or like Ketaxem, or
Ketaxem,
like
perfect.
GI cement. So you shouldn't use the Fuji 9, for example. It's too thick.
Too thick. You're going to struggle to seat it down very well. So you want a runny, not an RMGIC, absolutely not. You want a runny GIC, a bit more like a luting cement. Okay.
Yeah.
And then load the crown up and definitely load it up good halfway. Keep in mind, because you haven't taken a whole heap off, you don't need a huge amount. And then just push it on. Okay. And then to clean it up, I usually just get some gauze and just wipe around all the excess initially. Then the strongest way to get that crown to sit down is the kid, because their jaw's a lot stronger than my thumb. And so I put a cotton roll in it. I get the kid to bite down really hard. Okay. And then I get my triplex and I just wash all the cement off and off you go. Then you get a floss with a knot in it and then you put it on and then you get your dental assistant to put their thumb over the top of the crown. You floss down and then pull it out and then go the other side, floss down, pull it out.
That can be tricky, right? That can be a little bit tight and annoying. In my experience, it has been. Have you found the same as well?
Absolutely, but you got to do it.
Yeah.
Otherwise, you'll glue the contact.
It's the stressful part of the procedure where you're like, okay, quick.
Yeah, spot on. But keep in mind, if you get a slower setting one, you got about 2 to 3 minutes. And that's where if you put it on and you look at it, you're like, shit, it looks like the one surface is sitting in the air. That's when you're thinking that's not on. Like it should be like 1.5 mils high, right? If you're looking at it, it's like it's low on the mesial, really high on the distal. And that's where my cavity is. That's where... Nah, and that's your time to get it off. Yeah.
It can be quite fiddly to begin with, but like you said, such an incredible success rate you get, and it's great to be able to intervene in this way, just so I can make sure that for the show notes, everything is correct and my understanding has been correct as well. So I'll summarize. You've done a wonderful summary here of the Hall crown technique, why we do it, why it's beneficial compared to the conventional technique, but just... there are still some scenarios whereby you may use the conventional technique with LA, occlusal reduction, zipping the contacts, and that is A, when you're doing a pulpotomy, B, when the caries is very subgingival. Is there any other times where you would veer away from the Hall crown technique?
When you've got that significant space loss, okay?
Yes.
You know, and then potentially, like if I'm doing a quadrant of dentistry, like the second primary molar's got a hole in it, the first primary molar's got a big hole in it, and the canine's got a hole in it. You can't Hall crown a canine. So I've got to numb them up. And then I might just say, I'm just going to knock out all 3 in one go. You know, I'm not going to get them to do all these Hall crowns, come in and numb them up. So I might do, you know, potentially a composite on the second primary molar if it's small. If it's big, I might do back-to-back crowns. You know, if one of them needs an extraction or whatever, I'll probably just move ahead and just, because I can get it doesn't take me long, I just get a quite nicer fit. Yeah, but you nailed it, mate. That's pretty much it.
Brilliant. Thank you so much. And that was all down to your wonderful summaries. So let's now, the last bit. Okay, Zirconia is a newer product to the market for children. It has been around for a little while now, but I haven't seen it in the UK. It's been used very widely, but perhaps because the bias of me not looking at what the children's clinics are doing in the UK at the moment. So tell me, my friend, how far are we in the Zirconia being potentially replacing metal, and what have been your experiences with it?
So we place quite a lot of them. They probably make up about 40% of the crowns that we place in comparison to Hall crowns and conventional crowns. The main reason is obviously aesthetics. Okay. Success rates are pretty similar between a stainless steel crown and a zirconia crown, if placed well. Okay. So why would we put them on? It's just purely aesthetics. That's it, on posterior teeth. Okay. So I would usually discuss with the parents and say, hey, look, your kid's got, let's just say they got all back 8 molars are decayed. I'll say, hey, look, all back 8 molars are decayed. Whenever I've got a cavity in the first primary molar, the success rate of fillings is pretty low. So I usually will say your choice is a stainless steel crown or a zirconia crown for a first primary molar. For a second primary molar, I'm a little bit more comfortable doing restorations on them, intracoronal restorations. Okay. So let's say they got that. I'll be discussing with them and say, hypothetically, let's say they need 8 crowns based on what I'm seeing. They're all really big holes. I will say to them, we can do 8 stainless steel crowns. Your success rate sits in that 95 to 97. Your main drawback is you're not going to love the way it looks. They're going to look a bit like jaws. So you're going to have, all these visible 8 teeth. So the other option you got is that we can do zirconia crowns. Now, the more visible teeth are the first primary molars. So you can do them all in white, all in silver, or you can do a mix. You can do maybe the front baby teeth in white and the back baby teeth in silver. And so then when the kids smile for school photos, you're not really seeing all that metal work. You're predominantly just seeing a nice aesthetic looking tooth. And Jazz, that would be our most dominant use. We don't commonly get that many parents who want to do like all 8 teeth in white because it costs more to do. They do take more time as well. They can take a fair whack bit more time if you're doing 8 of them. And the reason is it's a non-flexible material. So if we talk about zirconia for a minute, most dental practitioners are familiar with zirconia crowns or zirconia as a product for adult. We know it's not flexible. We know it's very strong and durable and compressive strength's excellent once it's cemented, but it's not flexible. So if you sat there with your fingers or, got a little and just banged on it, it'll fracture, okay? Which means you can't squish it on like a stainless steel crown for kids where you're like, my prep's not perfect, but I'll just push it and the crown will bend on. And that's why hawk crowns work, because it's a flexible material. So for zirconia, you have to prep the tooth. And it's a bit like an adult crown prep with no edge, no ledge, no feather edge, no shoulder, nothing. So what you do is you take about 1.5 mil to 2 mil off the top, and then you take roughly about 1 mil everywhere else. Okay, and then so pretty much you create like a ledge all the way. So usually the way in which I would do it is I'll take it off the top first, because it makes your crown shorter, so you're then having to remove less. Then I stay on the same burr, which is usually like a football burr. Then I take some off the buccal and the palatal, because you try to remove burr changes. That's what makes things quick. Then I get a stiletto burr or flame burr. You got to go below the gum. You're about 1 mil below the gum. And then you buzz all the way around, get all your edges away, clear the interproximals. And then for the new smile, you get a trying crown, which is excellent compared to that other brand called Sprig. The reason is you use the trying crown, which will get contaminated by blood products and things, and you try to fit it on. And there's a classic size and there's a narrow. The narrow is obviously designed for where you got space loss. And you try it on so it passively fits. So you're not forcing it. If you force it, you'll break it. So you don't want it rocking. You want it passively fitting on with still contact points established. Once you go onto that, you then go and get your white crown, the one you're going to cement. You get good hemostasis of the gingiva. So sometimes I'll use local because it's got adrenaline in. So I'll already have the patient numb. So whenever I numb a patient up for any procedure, I always numb through the interproximal gingiva to the palatal lingual. Every case I do. More so for zirconia. And then otherwise you can use like hemostatic paste, like 3M makes a hemostatic paste, because you would need much better hemostasis than you do for stainless steel crowns. And then fill it full of the same. You want a runny RMGIC potentially. Okay, so it take too long for you if you just go use just a thin like Keytac sem, or you want something you can cure with a light. Okay, but you still want it thin. You don't want like you can cement with Fuji too, but for posterior teeth it's a bit thick, and sometimes you can't get the crown down because the cement can't escape. So we use a 3M based product which comes in a syringe called RelyX. It's really nice material, and then you load your crown up, you put it on. And then I don't touch anything. I just set it. And so there's excess cement everywhere, but it sets really quite tacky. So it's a bit like a tack cure, but I'll set for 40 or 60 seconds. And then I just clean all the extra cement up. If you use Fuji too, it sets like rock. And it's really difficult to get out interproximally. And then you're done. That's it. Nice and easy. How long would it take? Look, I can probably do a stainless steel crown, a conventional stainless crown of tooth in about 3 to 4 minutes, okay? While zirconia might take me closer to 10.
This is because zirconia involves that buccal and lingual additional prep. And essentially, you're removing the belly of the tooth, right? You're just removing the undercuts.
Yeah, spot on. You just sort of, for the listeners, they can't see, but for those who are watching on YouTube, I am going to describe something. So, Jazz, I'm sorry for your listeners. They won't be able to see this, but I'm going to describe it. For those watching on YouTube, you'll be able to see this. So this is an anterior case, but I'll show you a posterior. So with it, you got to make them quite sort of peg-like. See, there's nice hemostasis there. I've got stainless steel crowns on the first primary molars, and on the anteriors, I've reduced the anteriors down to look a bit like a conventional crown preparation, and then I've cemented 4 zirconia crowns there. The gums look a bit like minced meat. They get a bit traumatized here, but they always heal up really quite nicely. And now I'm going to show a photo of a posterior tooth.
I'm just going to say, it looks a bit like a vertiprep in a way that you just, just went round, you got rid of all the undercuts, and it's not much of a margin.
No, you don't want a margin. You don't want a ledge.
Exactly.
So on the posterior tooth I'm now showing, you can see that I've actually created a ledge. That's what I was talking about before. So you create a ledge. It just gives you an indication of where to reduce. Then you cut that entire ledge away, which you can see there, goes under the gum. Then
this
you try the crown.
Man. This is a shoulderless vertebrate. Yep. Lovely.
And then that's your crown cemented. Yeah. So the crown's cemented on, sits quite nicely. You want it roughly the same occlusal height as everything else. And you want it sitting under that gum quite nicely. As I said, the gum will be a bit traumatized, but it will be okay.
Now, here's an interesting question then, because you just raised a really good point that you want it the same occlusal level. In this scenario whereby you're off a bit, then you're kind of like in the whole crown scenario, you are leaving it in super occlusion. Are you okay with that because you're used to doing it anyway in children and they adapt really well? Or are you a little bit more fastidious that you're going to start adjusting to equilibrate the bite?
No, I'm okay with it. I do try to get it a bit more even, but just for comfort. And particularly, let's say if I'm under general anaesthetic and I'm doing, a whole quadrant, I don't want just like them only chewing on a couple of teeth. It's just a bit uncomfortable. So if I can, I try to get it as close as I can. It won't be perfect, but we do know for the hall crown it can sit proud and it'll settle in quite well. So they're really good. The other place where they are so much better, which I actually personally feel they should replace entirely, is strip crowns. So anteriorly, right? So for a strip crown, it's the same sort of principle. You've got to do like that verti prep, get rid of the decay. The issue with strip crowns is the success rate's not great because it's resin. It just chips. Kids go put bloody carrots in there and they bite muesli bars and all sorts of things. And you just, in any pediatric dental program, when you're a first year, you spend all your time dealing with fractured strip crowns from the third years of the guys who graduated. And so your benefit of your zirconia crowns is they very rarely fracture. You need a really solid trauma to break it, which would have broken the tooth anyway. So your main drawback is they might debond. There's not much retention on them. So that's where we do cement them with Fuji too. So we are a thicker RMGIC on the anteriors, but they are such a better aesthetic result. You don't get discoloration throwing shoe. They work very well for pulpotomies. You can successfully pulpotomy an anterior tooth. They can mask if you've put silver diamine fluoride on it, it's black. So they look a lot better. They last a lot better, so they're a much more superior material. Your main drawback is if you've got a kid with heaps of crowding, it can be a bit difficult to try to get them to fit all together. So just tip for young players on that one. That's where strip crowns can help. But mate, I haven't done a strip crown on a primary anterior tooth in 5 years. And I'm so bloody happy I don't do them anymore.
And for those who are listening, I would encourage you just reference back to this video. We'll make a little handout because Tim, this has been absolutely amazing. We'll make a little handout. Do we have permission to use those images in that handout for Protrusive? Okay, amazing. So I'll put those images so you can easily download because they were wonderful. It really shines the benefits of this approach, and it's nice to know that a very significant percentage of the time actually you're using this, and also to learn about how you've no longer pretty much using strip crowns anymore. That was amazing. You've answered pretty much all my questions in terms of the technique itself. Now, I know you do some teaching in Australia and maybe more as well. Before we get to that, I want to say, pay you a compliment, Tim. If I had your accent, right, which I love, by the way, if I had your accent, I would do the dental version of Aussie Man Reviews, right? I would just think it'd be so funny and good to see these dental procedures happening. And then you just honestly, I really enjoyed listening to you today. The hour went by really quickly. The audience would have loved you as well, the Protrusive. Please tell us, how can we learn more from you? I know you're active in the education circuit, and I think for everyone, it's nice for them to be inspired by what we discussed today, but I think it's very fiddly, and to just secure the protocols and so much more to it, to get hands-on experience, how can they learn that from you?
Yeah, absolutely. So we have a free dental website called Kids kidsdentaltips.com, and you can just scrub. There's a whole heap of articles on there, how to manage permanent traumas, do sphencpulpotomies, how to extract primary teeth, prevention techniques, fluoride toothpaste, anything you can think of for peds is pretty much on there. It's free access. There's not a great deal of videos yet, Jazz. I haven't quite got to that point yet. There's some free lectures on there as well that you can view. Otherwise, we do hands-on programs in Australia, with which I'm actually doing one. I'm doing a 4-day one coming up on Thursday, the next few days. We haven't done any internationally, but Jazz, if you think there's a place for it in the UK, I'd be very happy to come across for a nice trip to the sunny UK and do some courses there. But otherwise, if you are interested in doing something like a zirconia crown, you can find videos of like how to on the New Smile, so NUSMILE, the New Smile website will have like how to videos, and they do tend to run international events as well. I just don't know if they've gone into the UK, because I know that your market is quite different in regards to NHS and private. So for example, in Australia, there's really no very limited public funding dentistry where it's all private, which has got its own problems. If you don't have money, you can't pay for it. It's a bit like America. Conversely, in the NHS, I know you got a lot of restrictions on time and how much, you really encouraged to get through things quickly. So, and perhaps that's why they haven't targeted that market previously. Look, if your listeners, there's a good demand out there, so I'm very happy to come across and run a course on hall crowns, zirconia crowns, restorative materials, local anaesthetics and stuff. Yeah,
I think that'd be wonderful. So I think if there's enough comments below, we'll reach out and see. But I think what you've talked about today was absolutely fantastic. In 1 hour we actually managed to cover a lot. So I would encourage you. I'm going to put the website. Just say the URL again for my benefit.
It's kidsdentaltips.com.
Lovely. I've seen the website. That's how I managed to reach out to you guys. If you want to learn more about pediatric dentistry, check out Tim's website and check the articles out there as well. And if you are in Australia, there's a good whack of Protrusive in Australia. Please check out Tim's courses, and maybe coming soon to a nation near you. And Tim, I wish you all the best, because I really love your education style. I just love people like you who are so direct and honest and just full of little nuggets and tips. And I know for a fact that Protrusive would have loved today's episode. So we're going to make a little handout for them as well. So Tim, thank you so much, my friend. I'll put all the links in the show notes. Are you active on social media?
Not too much. I am in Facebook, and I do a few posts and things like that as well. But I just time poor, Jazz. With 3 young kids.
I can relate. I can totally relate, my friend. But no, it was so nice to connect you on Facebook, and thanks for replying to me and being so wonderful on here. I really appreciate it, Tim. Thank you.
My pleasure. Thanks for having me. I think you do a great job as an interviewer, mate. You're very engaging as well. So thanks very much for having me.
Amazing. Thank you. Well, there we have it, guys. Thank you so much for listening all the way to the end. If you'd like CPD or CE credits, scroll down, answer the quiz, and get your CPD. You've done the hard work. Like, how many times do you have to sit through boring webinars to get your CPD? Well, you've just enjoyed Tim's fantastic commentary and explanation of this awesome technique. And now, to validate your learning, to be able to reflect and get a certificate, you can just answer the quiz on Protrusive Guidance if you're on one of our paid plans, which I think is the best value educational resource on the planet. But of course, I'm biased. It's fully tax deductible, as you know, and it helps Team Protrusive to grow and to make better content. So if you're not already on there, head over to protrusive.co.uk/ultimate, and that unlocks vertepreps for plonkers, or sectioning school, or the various other masterclasses we have on there, especially, and of course, the community of the nicest and geekiest dentists in the world. The infographic is also there. We also have a secret space called Protrusive Vault, which has got all the downloads from over the years. And lastly, Tim is such a cool guy to learn from. I know he does his courses in Australia, so the next one is in November. So if you scroll down, I'll put a link to his course in Australia in November, predominantly for the Aussie and Kiwi audience, but if you're in Asia, or sometimes you want to make a tax deductible trip to Australia, then this is a great reason to go. Tim is absolutely brilliant. And of course, I'll put a link to his website. And with that, I will say thank you so much, guys, honestly, for listening to the end. If you enjoyed this episode, please send it to a colleague. This is how we grow. All the best. I'll catch you same time, same place next week. Bye for now.